Hey, I'd like to welcome everybody. And on the behalf of the Basic and Translational Science Committee, I'd like to welcome you to the webinar, Immunotherapy for Mucosal Head and Neck Cancer, Discussion of the Current Lab Landscape and Vision for the Future. I am Natalie Silver, Associate Staff at the Cleveland Clinic, and Carissa Thomas, Assistant Professor from UAB, will be co-hosting. Chad Brenner, Associate Professor from the University of Michigan, will be moderating the panel and discussion. We are really excited and fortunate to have an amazing group of experts in the field of immunotherapy here today with us, who are paving the way for clinical translation of novel treatments for our head and neck cancer patients. Our speakers are Ravi Uppaluri, Director of the Head and Neck Surgical Oncology at the Brigham and Women's Hospital and Dana-Farber Cancer Institute. Among many other roles, Dr. Uppaluri is PI of clinical trials integrating immunotherapy in a surgical practice. Clint Allen is the Surgical Oncology Program Acting Chief at the Center for Cancer Research at the NCI. Sana Karam is a Professor of Radiation Oncology and Vice Chair for Translational Research at the University of Colorado. And Tulia Bruno is an Assistant Professor in the Department of Immunology at the University of Pittsburgh and an expert in the role of B cells in head and neck and other cancers. All of our esteemed panelists are successful PIs of translational research labs focused on immunotherapy in head and neck cancer. We will begin with a brief introduction to immunotherapy clinical trial landscape from Dr. Thomas, followed by 8 to 10-minute lectures from our panelists. Dr. Chad Brenner will moderate a discussion session and incorporate questions from the audience. Please feel free to enter them into the Q&A and we will try to get to them during the discussion. We may go over about 10 or 15 minutes of the hour to accommodate the discussion. And without further ado, I'm going to turn this over to Dr. Thomas, who's going to give us an introduction.
All right, great. Thank you, Dr. Silver. Can everyone see my screen? Okay, so tonight I'm going to kick off and begin with just a brief introduction, examining the evolving paradigms of immunotherapy and how immunotherapy is being incorporated into our multimodal treatment of mucosal head and neck cancer. And really just trying to set the stage for our expert panelists. And I have no disclosures. So immunotherapy is now part of our standard of care treatment for head and neck cancer. And it really is one of the preferred treatments for recurrent, unresectable or metastatic disease, as we know, and as stated in our current NCCN guidelines. The key clinical trials that really established immune checkpoint inhibitors as standard of care for recurrent metastatic head and neck cancer include KEYNOTE-12, KEYNOTE-40, and CheckMate 141. These studies demonstrated that both pembrolizumab and nivolumab improve overall survival as a second-line treatment in platinum-refractory recurrent metastatic disease. These trials were then followed by KEYNOTE-48, which established pembrolizumab with or without chemotherapy as superior to our standard of care treatment in first-line recurrent metastatic head and neck cancer. But now we really want to move beyond the recurrent metastatic setting, and numerous clinical trials are in progress. They're examining how immunotherapy can be combined and sequenced with our treatments of surgery, radiation, and chemotherapy. And ideally, and hopefully through these clinical trials, we're going to identify where the addition of immune checkpoint inhibitors are really superior to our standard of care treatments. So just to highlight this a little bit further, so the application of immunotherapy in the neoadjuvant space is being investigated primarily through three main treatment paradigms. One is as neoadjuvant immunotherapy monotherapy with or without adjuvant immunotherapy. Dr. Uppaluri, one of our panelists tonight, has led a phase 2 trial examining neoadjuvant adjuvant pembrolizumab in resectable locally advanced head and neck cancer. And this trial demonstrated both the safety of this approach, as well as the fact that there was any pathologic response of about 44%. There have been several other successful trials in this space that I mentioned on this slide that have demonstrated similar results. A second approach is to combine our anti-PD-L1 and our anti-CTLA-4 as a neoadjuvant therapy. And there have been trials reported such as Incision and Schofield et al. Finally, a third strategy is a neoadjuvant immunotherapy with chemo or chemoradiation approach. Another one of our expert panelists, Dr. Crom, executed a phase 1 trial looking at neoadjuvant hypofractionated stereotactic body radiation therapy with a single dose of durvalumab. And currently, right now, we have a ongoing phase 3 clinical trial, Keynote 689, that's examining neoadjuvant pembro as well as adjuvant pembrolizumab versus our standard of care treatment, and those results have not come out yet. An alternative approach or other clinical trials have looked more at what's termed immunochemoradiotherapy, or the addition of immunotherapy to curative intent chemoradiation. And this has been done in several phase 3 trials. Several of these trials have been completed, for example, Javelin, and as many know, these had negative results in the trials. And there is one trial in this field, HN005, that is still pending. What we learned from these trials is that perhaps simultaneous immunochemoradiotherapy is not as effective. One theory being that the immune system needs some time to recover prior to the initiation of immune checkpoint inhibitor treatment. And so ongoing trials such as RTOG 1216 are really examining immunotherapy now as a sequential treatment option. And I'm going to wrap it up there and just conclude by saying, this is a really kind of dense and complex, but really exciting space to expand our use of immunotherapy and hopefully improve outcomes in head and neck cancer. And I'm going to turn it over now to our expert panelists to expand upon our current understanding of immunotherapy and mucosal head and neck cancer. Stop sharing.
Thanks, Chris. Thanks to all of you for having me organizing this very interesting symposium, and also invited me to speak here. So I'll share my screen. Everybody can see this? Chad, give me the thumbs up, please.
Looks good.
Okay, so I'll set the stage for the talks today, hopefully, with respect to discussing neoadjuvant approaches, and I'll focus on anti-PD-1 therapy and some of our work on T-cell dynamics and clinical implications. So these are my disclosures. So I'll really focus on talking about monotherapy approaches, the anti-PD-1 and head and neck cancers, and our work around that, and some of the correlative work that we've done looking at T-cell dynamics in this setting. Hopefully through this talk, I'll also give some background that'll set the stage for a couple of the talks upcoming. And as Chris pointed out already, there's been an evolution over the last decade, a couple decades now, from the early 2010s to now, of an extension of immunotherapy across the clinical spectrums that we see in head and neck cancers. So she obviously already highlighted some of this in terms of talking about concurrent therapies, and trials have sort of been negative in that area. And so we and others have been thinking about neoadjuvant approaches prior to surgery for several years, and that's really the focus of my clinical and research efforts at this point. So the question is, why preoperative therapy in head and neck cancer? As Chris again already pointed out, there's been negative studies in the concurrent settings, and in the this has led to this idea that by thinking about approaches again in these high risk, locally advanced, and this really talks about HPV negative or oral cavity site patients, that they could benefit from new approaches. A second concept with respect to why preoperative therapy is this idea that mechanistically PD-1 therapy may be more effective with the antigen, the tumor burden still being present. And finally, and as I and several others today will talk about, it offers a really discovery approach to look at correlates of response and resistance and understanding head and neck immunobiology. So again, the standard approach, as we all know, is kind of outlined at the bottom here, where surgical patients they go through a scheduling window prior to surgery, and these trials, these window studies, introduce a therapeutic intervention with biopsies introduced at baseline and post-treatment, along comparisons, which allow then sort of biomarker studies, and then hopefully a therapeutic intervention also. So this approach has now been used in many different settings. So in the next couple of slides, I'll kind of skim through it pretty quickly, but it's to emphasize that we and others, many others have now used these approaches in the neoadjuvant setting. These trials, and not every single one that's published is shown here, but just select ones. And I'm not trying to have you look at all the numbers here, but just to highlight that there have been monotherapy, PD-L1 or PD-1 blocking approaches. There have been trials with combination therapies with anti-PD-L1 therapy, including other checkpoints. And as Dr. Allen will talk about with TGF-beta trap. There have been trials with combination with radiation therapy and trials now that are coming out combining chemotherapy with PD-1, PD-L1 blockade. So there's clearly been a lot of work done, but just to take a step back in, I want to talk about why this is potentially a good idea. And this question has been raised many times over the last few years. Does this approach of introducing immunotherapy before surgery really make a difference, or does it just delay curative surgery? And probably the best evidence for this is a study from melanoma, the SWOG 1801 study, where, as many of you know, patients with resectable melanoma were randomized to receive either standard of care surgery followed by adjuvant pembrolizumab, or neoadjuvant therapy followed by with 3 cycles of pembrolizumab followed by surgery, and 15 cycles later after surgery. And this trial was really dramatic in showing the event-free survival was significantly improved in the neoadjuvant plus adjuvant cohort compared to the adjuvant cohort, with a really strong hazard ratio of 0.58 as shown here. And this was consistent with our thinking that the neoadjuvant immunotherapy prior to surgery induces an immune response that can give you durable responses, resulting in these kind of dramatically improved clinical outcomes. So we first came up with this idea many years ago, and these trials were written in 2012, 2013 by myself and Doug Atkins, my collaborator, where we took newly diagnosed advanced stage 3-4 HPV negative head and neck cancer patients, and completed this initial trial, which we call cohort 1, where patients receive a single dose of pembrolizumab, standard of care head and neck cancer surgery, followed by risk stratified treatment. And then we looked at these 2 endpoints of recurrence rates and pathologic tumor response, which I'll talk about in a second. We completed a second cohort, which was published last year, where instead of 1 dose, we gave 2 doses of neoadjuvant therapy, and then completed our standard of care treatment after that, and looked at this pathologic response rate, which again I'll talk about. So this has really been our foundation for many of our studies, and has led to many lessons that we've learned from this. So the key outcomes from both these studies that we did was that overall, this is a very safe approach. We really didn't see any new signals in terms of adverse events or unexpected surgical delays, which is obviously a big concern. And the clinical outcomes were good, and we see these pathologic responses. This is what it looks like, where you have a necrotic tumor bed here after giving immunotherapy, some viable tumor, and we quantitated this into a 0, 1, or 2 scale, where 2 was greater than 50% sort of tumor necrosis in the overall bed, 1 was between 10 and 50, and 0 was no or less than 10% response. Using this approach, we found that in both cohorts, 1 and 2, about half the patients responded and half didn't respond, which was, I think, an interesting finding itself. But importantly, after 2 doses of therapy, we saw a doubling of the amount of higher path responses that we saw in the initial study. Now, these trials were not powered to really compare this, so that's a big caveat here. But I do think that's interesting that increasing doses or increasing the timing may improve these path responses, which are really critical for looking at these studies. So the question is, what's the mechanisms and what else have we learned here? And from a correlative standpoint, the thinking is that the giving immunotherapy before surgery activates sort of pre-existing anti-tumor immunity that's unleashed, and that results in these pathologic responses. And then this antigen burden then, with functional lymph nodes being intact, results in a sort of vaccination approach and enhancing durable responses which act through and give you better clinical outcomes. So there's multiple key sort of insights that we can gain from these sort of correlative studies, looking at biomarkers, mechanisms, immunoevasive mechanisms, and comparing the different tissue sites, the tumor, lymph node, and blood. That gives us great opportunities to look at that in these kind of studies. So one of the common techniques that we've all used, and you'll hear about a little bit today, is single-cell RNA sequencing. This is a technology that extends our older sort of techniques of bulk RNA sequencing to look, instead of the whole smoothie, at individual components that make up this and identify the different cell types that are responding or are associated with responsive resistance. So many of us have done these studies where we've taken these samples, dissociated them, and again, the head and neck opportunity tumor site offers us a great opportunity to do this, and perform these single-cell RNA sequencing, looking at the transcriptome within the tumor cells, or looking at the T cell receptors, which can barcode the T cells in the tumor specifically, which allow comparison of these cells through treatment. So we did this study working with Kathy Wu here at the Dana-Farber, where we looked at matched samples pre and post of responders and non-responders, again, categorized based on the pathologic tumor response criteria I told you about. And again, to get through this, for those of you who don't know, some of these large-scale complex data sets are reduced into this two-dimensional structure called a UMAP plot, where it reduces this. It's a dimensionality reduction approach, which has its caveats, but overall confers an ability to look at specific cell types and how they cluster together. And we saw overall that there's a cluster of T cells. We're looking at only the CD8 T cells in the tumor that are called exhausted T cells or non-exhausted memory-like cells, which, if you look at signatures from previous studies, correlate with tumor responsive cells in this exhausted cohort, and sort of virus-like or bystander cells that infiltrate many tumors in this sort of bottom non-exhausted memory-like subset of cells. And interesting, what we found is that responders compared to non-responders, R versus NRs, had really significant increases in these exhausted T cells, again, in the responder populations. We've done further studies looking at the specific signatures within these cells. So if you could look at the specific sort of red subset of cells, when we compare those to other cells in this data set, we see that on the left side, that's these red cells, have very high expression of this transcription factor, or this protein called ZNF683. So that highlighted that these cells were really likely these cells called tissue resident memory CD8 positive T cells. And these are derived from precursor subsets that end up residing in tumor sites, and they allow rapid responses to infections and cancer. And they're anchored in the tumor by binding to epithelial cells. When we looked at this, a marker of these cells called CD103, which you can see on the left side with the white sort of staining here, is that responder patients have these cells already at baseline, even before getting immunotherapy, suggesting this is a biomarker response. Just for the sake of time, I'll skip through it, but we can also look at T cell receptors on these. And again, I won't, because of the sake of time, I'll skip forward here. So the question is, where are we going with this work in the next few years from a clinical standpoint? Obviously, a lot of important correlative studies to do, but with respect to where we're headed, we first presented our initial experience with neoadjuvant therapy in 2017 at ASCO, again with my collaborator Doug Atkins at WashU. And in the sort of 7-8 years since then, Merck, as Carissa pointed out earlier, started this KEYNOTE-69 phase 3 clinical trial, which will be the definitive trial to try to address this question of in HPV-negative head and neck cancer, whether introducing neoadjuvant immunotherapy prior to surgery compared to standard of care, and then stratifying patients again for high risk or low risk pathologies, will show an impact of immunotherapy in neoadjuvant setting for these patients. So this trial actually has completed accrual, and it should be reading out in the next year or two, and we're all excited to see where this is going, even whether it's positive or negative. So in summary, again, just to get through everything here, this is a safe approach. Early data suggests satisfactory clinical outcomes. I highlighted some of our clinical studies, and we're really looking at combination approaches and awaiting the results of the 689 clinical trial. I'll stop there. Thanks to our patients and families and everybody else in my group who has done this work. Thank you.
All right.
Thank you so much. Yep. Next, we have Dr. Allen.
All right, very good. Well, thanks, Dr. Blair, for leading us off with that. And it's really a nice kind of comprehensive introduction to segue into, I think, some of the other things we're going to talk about. So nice to meet everyone. Good evening or good afternoon, depending on where you are. I'm Clint. I'm here at the NIH in the Intramural Research Program in the National Cancer Institute. So the great assumption that we all make, and I think it's a safe assumption, is that activating the immune response against a cancer in that initial treatment phase is a good idea. And this is, I think, really based on another concern, which is that these standard of care treatments that we do, we probably don't remove or kill every last cancer cell, right? If we did, people probably wouldn't have recurrences. So the concept here really is that if we can find safe and effective ways right from the get-go to activate a patient's immune response against the tumor, that it could help, kind of clean up some of these residual cancer cells that are left over and improve recurrence-free survival. And that's really what we're trying to do, right? We're taking these HPV negative, typically oral cavity advanced stage head and neck cancers, where we know with standard of care treatment, they have, for example, 2-year recurrence-free survival rates of 50, 60%. Like, that's not great. And so we're trying to make that better by introducing these immunotherapies around the time of standard of care. And so I have no conflicts. I'm a federal employee. I can't have conflicts. And what I'm going to try to do is tell you a scientific story to hopefully convince you why neoadjuvant really makes sense as a treatment strategy. So as Dr. Ubelary mentioned, we have the opportunity to do these window studies. And so here at the NIH, we did this window study with this compound, again, in newly diagnosed advanced stage HPV negative cancers, typically all oral cavity cancers. And in that window period, we gave them 2 doses of this drug called bintrafusp alfa, which is it's a bifunctional drug. It's one drug, but it does 2 things. It both binds and blocks PD-L1, which you heard about from Dr. Ubelary. And then the backside of the antibody has this kind of decoy TGF-beta trap. So it binds and neutralizes TGF-beta in the microenvironment. I'm going to explain to you why we think that's a good idea. But the major results of this clinical trial was, we only treated 20 patients, but we've got an 86% 3-year recurrence-free survival, which is, of course, much better than expected. Again, the caveat of a single-arm study. And it was well tolerated, and we saw a wide range of these pathologic responses in the tumor, again, like Dr. Ubelary mentioned. But we had this opportunity, right, because it's a neoadjuvant study, so we could get biopsies before the treatment, give the 2 treatments, get biopsies after the treatment. And as has been explained, we can do single cell sequencing, and because each T cell expresses a unique TCR, if we include TCR sequencing in that single cell sequencing, we can actually track what happens to individual T cell clones, we call them, individual T cells in the tumor and elsewhere in the body before and after treatment. And this is a really powerful way to look at the dynamics and the changes of what's happening with the T cell arm of the immune system, which is what we're trying to activate, because we know that's what can kill tumor. So as you've heard, when we paired T cell receptor sequencing with single cell sequencing, we can group T cells together by clones because they share a single TCR. And then we can look at their gene expression profile. And this is a UMAP of the gene expression profile we saw in T cells in these patients. But by looking at what genes are expressed in these T cells, we can basically give them names, right? So we know that all these kind of red and yellow and pink T cells are exhausted because they express these exhaustion or proliferation or activation markers. And we know these other T cells that are color-coded in blue or purple are non-exhausted and have like memory features and seem like they just kind of came in from the blood into the tumor. And we can give all these T cells names, but giving T cells names is kind of only half the battle. What really matters is we want to figure out which T cells are just T cells that kind of circulated in from the blood and just happened to be there when you did the analysis, the assay, versus which T cells are truly tumor specific or mutation specific, right? We know these T cells that come into the tumor are targeting mostly mutations that yield little peptides that are slightly different from your own self peptides, and so they can be recognized by the T cells. And what we did in this study was we cloned out a bunch of the T cell receptors we had sequenced, and we actually figured out for a panel of T cell receptors which ones were truly specific for the tumor and which ones were just kind of passenger T cells that we think happen to come in from circulation. And lo and behold, we found what other people have found, which is that the tumor-specific T cells are these exhausted or proliferating T cells, which you kind of see overlaid here on this UMAP. All these red T cells fall into the exhausted clusters. And in fact, when we look after treatment with the bintrafusp alfa, the 2 doses, and we compare it to before treatment, it is those exhausted tumor-specific T cells that are expanding. This is log 2-fold change of the different T cell clusters. So it's not really the T cells that we think are just kind of there because they came in from circulation that are activating and expanding. It's truly the tumor-specific clones that are expanding. Now, something else that you really have to understand, and Dr. Belluri mentioned this, is this idea of tissue residency. So when a T cell that's tumor specific comes in from the blood and enters the tumor, it engages its TCR, but because it can't kill all the tumor cells, it has what we term chronic TCR signaling. And T cells that chronically signal their TCR change in many ways, including expressing these exhaustion markers like PD-1, CTLA-4, TIM-3, LAG-3. You've heard about all these. But in the presence of TGF-beta, like is shown here, chronic TCR signaling plus TGF-beta leads to really significant upregulation of this residency molecule or an adhesion molecule called CD103. And CD103 binds E-cadherin, which is on tumor cells. So T cells that are tumor specific come into the tumor. This tissue resident program gets activated and they get stuck in the tumor. And can we measure that? So what we're looking at here is the frequency of T cell receptors that we identified in the tumor as being tumor specific or not tumor specific, measuring those in the blood. And what you'll see from this green arrows, these little gray bars are the frequency of T cells that are tumor specific in the blood before treatment. And the major conclusion here is that they're practically undetectable. This is kind of actual evidence of tissue residency of these tumor-specific T cells, right? But after treatment, these T cells that are tumor-specific become readily detectable in the blood. This is looking at it just a different way. All these orange and yellow and red lines, these are the pre-treatment frequencies in the blood, and after treatment, those frequencies in the blood become detectable and really expand. This is just validation at the protein level that CD103 expression on the CD8 T cells in the tumor that are tumor specific is selectively reduced after this treatment. Other things on these T cells are not reduced, like LAG-3 or CD39, it's the CD103. And importantly, the amount of reduction of CD103 expression on these T cells in the tumor associates with how well they emerge into the blood. Just kind of another point suggesting that there's, emergence from the tumor of these tumor-specific T cells that are trapped there in the blood. So this is my last slide. And what's the implications of these data? Well, the tumor, and I know this isn't specific for head and neck cancer. This is identified in a lot of tumors, but especially head and neck cancer because there's lots of E-cadherin expression, which is the ligand for CD103, really acts as a reservoir for these tumor-specific T cells. And if all you did with a newly diagnosed head and neck cancer was cut it out or chemoradiate it, you're likely removing or killing the vast majority of that patient's anti-tumor T cell response. And unless you take the opportunity to do something before surgery or before chemoradiation to release some of those T cells into circulation so that they're not removed with surgery or not killed off with chemoradiation, we've probably missed a tremendous opportunity to help that patient by boosting their anti-tumor immune response. All the data I showed you is in that paper, and I'm going to stop there. Thank you very much.
Well, hello. I'm going to talk about the combining radiation and immunotherapy as a path to eradication of the neoadjuvant platform, just in the way of disclosures, mostly all actually research grants. So just radiation and immunotherapy kind of meld very nicely together. You get this really nice synergy and this amplified delta when you combine radiation with anti-PD-L1 or anti-PD-1, as you can see here in blue in these two models. And this is, many of us have shown, many of the people across the globe have shown this is mediated via activation of both CD8 and CD4 T cells, and also infiltration of these cells. Not only they're activated, but they're now intratumoral infiltration. You can see them getting into the core of the tumor. So this is great, but my goal in my life is to see eradication, not just tumor growth delay, to do something short for our patients that kind of get rid of the tumor altogether without the necessity of too much therapeutics. So we decided to add combinations and permutations we published over the years. And what you can see here is even with doublet immunotherapy, you do get more tumor growth delay, but ultimately all these mice in multiple models succumb to progression due to local progression of their disease. So in exploratory analyses and mechanistic studies, we identified one of the mechanisms as to how this resistance happens is what I call the resurgence of Tregs. So yes, you need the stimulation, the inflammation from radiation, which is a powerful force there. But as the body is wired, as the immune system is wired, you get repair phase. And during this repair phase, Tregs are one of these mediators. So we reasoned then, let's take like when the tumors are right coming back and treat them with Treg depletion with anti-CD25 pharmacological depletion. And now we are seeing eradication. These two mice did not eradicate because they did not deplete, but the rest did eradicate. And how dare I see eradication is because we re-challenge these mice, and even on re-challenge, they never regrow. If you put them in any compartment in the body, the lung, the contralateral buccal, whatever it is. But if you re-challenge with a different tumor, say colorectal or some other tumor, they do regrow, suggesting that the memory is antigen-specific T cell memory. So then the question came up, actually was one of the reviewers, show us the principal components. Do we even need radiation? Maybe anti-CD25 alone will work. Maybe, anti-PD-L1 will work. And we did all this work. And the bottom line is you need both. You need to inflame, recruit, and then you also need to suppress the Tregs. So this is the combination here. Interestingly, the old generation anti-CTLA-4, which is not a Treg depleter, did not do much even in combination, even in triplet combination. You get more tumor growth delay with the triplets and the doublets, but you don't get the eradication that you see here, where 70% of the mice don't recur. And to understand why that is, what is happening, that we're generating what I like to call the systemic immunity. We took the mice that cured and re-challenged them and took blood and draining lymph nodes and compared them to control before and after treatment. And what we, multiple findings, but the key findings here I'd like to emphasize is the looking at the draining lymph node, the main compartment here that is driving the response. I'll cut to the chase. You see really this remarkable activation and stimulation of the dendritic cells. Whether you look at CD80, CD103, or Ki67, they're really happy and excited, and they're jacked up in their numbers and their activation. Now, if you look at the blood and the lymph node, you see also pan activation of CD8 as well as CD4 T cells. So we then thought, well, the standard care, I'm a physician scientist, what I treat in the clinic is I do bilateral neck irradiation, contralateral elective node irradiation. So with these data that are clearly identifying the lymph node as a central compartment for the immunostimulation, we asked the question, what happens when we do this elective null irradiation, particularly in the setting of radiation immunotherapy? So to do that, we did multiple animal models, but this is for demonstration. We did both buccal implantation as well as flank implantation, but we also did metastatic models. We only irradiated the buccal, so the flank was not irradiated. And we did tumor only in the orange, or tumor plus elective nodal irradiation bilateral. And we looked to see what happened. And surprisingly, in cold tumors, hot tumors are a little different in terms of the local effects. There was no difference in tumor growth with cold tumors. But what was really shocking to me was the distant tumor. In the elective null irradiation, 71% of the mice recurred, whereas tumor only irradiation, only 30% of the mice recurred, suggesting there's an effect systemically with elective null irradiation. So we wanted to understand what's happening because we're not even touching the distant tumor with the radiation. And what we found is that there is definitely with the tumor with ENI, there's significant reduction in T cell activation systemically. This is in the blood. You can see decrease in the activation markers of both CD8 and CD4 T cells. This is a bird's eye view. That is a nice summary. I like to put it. It's not as quantitative, but it really captures the bottom line here. Is in the local tumor microenvironment, you see with ENI, you see this reduction in dendritic cells. You see a reduction in CD4 and CD8 T cells. But really significant here is what happens in the distant tumor when you're irradiating the primary. With elective null irradiation, marked reduction in CD4 and CD8 T cell activation. So great, are we ready to just, I want to stop irradiating elective nodal in my patients, but are we ready? What about regional recurrence? Do we have to worry about it? Particularly in, HPV positive disease, which is a disease that, as we all know, is notorious for nodal spread. So in these mice, we do see regional metastasis, and it happens much delayed. We watch these mice up to 6 months, and it's around 60 to 200 days or so. We start seeing recurrences in the non-irradiated, or in the lower cervical chain, what we call, and these mice die very quick. And we have a paper coming out. Hopefully, we're submitting very soon on mechanistic insights for that and mechanisms to salvage, ways to salvage this. So the question that came up, how do we balance these forces? How do we maintain systemic immunity while at the same time preventing regional recurrence or nodal recurrence? So we did multiple approaches. First is metachronous neck dissections, kind of like multiple people on the panel and audience or surgeons. So in the old days, we used to do staged neck dissection. So this is same idea. So we did the neck dissection after the radiation immunotherapy 10 days later. And you can see here, we can combat regional recurrence while maintaining systemic immunity as well as local immunity. And then we just, with thinking of translation, do we really want to do stage and all of that? Can we limit the treatment to just a sentinel lymph node, given that what we know is that's where the cancer cells usually are kind of migrating to initially. So we did that with both radiation and dissection. We did sentinel lymph node dissection and sentinel lymph node irradiation. And the answer is boom, yes. You kind of control regional progression and while maintaining both local and systemic immunity. So translational efforts, Ravi and Clint did a wonderful job with giving the prelude to this. We did run the phase 1/1b clinical trial, and I want to emphasize a few things. These are HPV negative, locally advanced. The dose of radiation is important. The choice of immunotherapy is important in the context of radiation and how many cycles we're giving. We only gave 1 cycle of durva, critical. We gave it on the same day as the radiation. The radiation dose was 6 gray times 3, 6 gray to PTV, 8 gray. We learned later that, when you heat up the GTV to 24 gray, we got better responses. And then we waited about 3 to 6 weeks of surgery. The expansion cohort was mostly 5 to 6 weeks. That's important as well. And all the post translational correlates were done right before surgery. We did give adjuvant durva. Some patients refused it, but or did not complete all 3 cycles. And I would love to comment in the question and answer session of whether this is important or not. And then patients went to follow up. The patients that were CR and MPR, once we got comfortable with it, did not get any adjuvant chemo or radiation unless they had NCCN guidelines criteria to get chemo or radiation or both. The radiation was, this is an example, just gross disease only, anything we see grossly with PET MRI. These are the response rates measured as MPR-CR, same definition that Ravi talked about. We had, just really was unexpected, pleasantly so. We had really great MPR and CR, so we actually called anything below MPR as non-responders. So responders are defined as MPR and CR. So these are clinical correlates. I hesitate to use word biomarkers because the sample size was small, but in terms of clinical correlates, time to surgery was a good correlate. The other thing was the dose of radiation in this trial with durvalumab, and this dose of radiation was also a correlate. We did not see the lymphopenia that we normally see with conventional chemoradiation after 6 weeks, where you could actually have systemic lymphopenia all the way up to a year. In terms of imaging correlates, and I saw a question in the chat, which is really fascinating, like clinical exam as well as radiographic exam. So for clinical exam, we do see, like this is a gentleman I treated, and you do see gross, response, and, on palpation or scope exam or any of that, you see the response really well in terms of this disappearance of the tumor, particularly if you wait long enough. For imaging, an area of huge unmet need for, I know there's a lot of CD8 PETs and all that, but the PET gave me nightmares where I see this inflammatory signal. CT did not correlate, and neither MRI. So for all of those of you out there who study imaging, please develop some better biomarker imaging studies in the setting of radiation immunotherapy. For tissue, biomarkers correlates. So we did spatial immunofluorescence, multispatial immunofluorescence, and you can see here the red is amplified for CD8 T cells, massive infiltration in the responders. This is a guy that is truly a non-responder. He actually, his tumor progressed, and you can see it at 5 weeks. The tumor started flourishing, so did not have, he was more of a desert. In terms of the CPS score and PD-L1, a common question. And I want to emphasize here that this is in the context of radiation, right? So neither one correlated. But what I'd like to also remind you of is these are data that we've published or about to publish. Radiation itself induces PD-L1 in the tumor microenvironment. It jacks up the CPS score on its own. So maybe it's the reason it did not correlate is because now you're giving a target to the anti-PD-L1. I don't know, but I don't think I personally, we'd have to validate on large trials with radiation, which we don't have yet, but it is not a good correlate in the context of radiation immunotherapy. Immunosuppressive T cells that in the denominator is a good correlate as well. So CD8 T cells definitely correlated, but the better correlate is the ratio of CD8 to Treg ratio to Tregs. Let me give you an example here. Again, the red is CD8 T cells. You can see a lot of red in the responders. But this guy here in patient 0102, you see he did have a lot of red. At the beginning, after the treatment, a little bit of red at the beginning, but so the CD8 did infiltrate, but with that came a lot of Tregs. So the CD8 to Treg ratio was low. This gentleman, he just became a desert. This is the same patient I talked about a little earlier. So what about the blood? I mean, can we develop something that could apply across the globe? Wouldn't that be nice? So it's an area that I'm very passionate about. So we did a lot of site-off, and we have a paper, hopefully we're prepping soon for single cell. Back in the day, I had very petite funding, so I didn't do a lot of single cell stuff, but we're now gearing up to get that together. But in the blood, what we found is it was great hits. So myeloids and activated CD8 T cells, I like this figure a lot better because like the blue bubble is a T cells, the brown bubble is a myeloids, and the pink bubble is the B cells. You can see from, in the responders, you see this is interferon gamma, TNF alpha, IL-2, TBET, you see marked activation of the T cells. Whereas in the non-responders, you don't see the activation from pre to post. At baseline, the myeloid stood as a biomarker in terms of, or as a correlate with increased expression of TGF beta, IL-17, and DNAM. The CD4.
I'm going to interrupt and ask us to wrap up when you can.
Yep. I'm almost done. CD4 effector memory T cells we're about to validate this. We've expanded our cohort, and so are the CD8 effector memory T cells. And with that, I'd like to thank my patients, first and foremost, our clinical trial team, and my wonderful family, which is my lab. Thank you.
Thank you so much.
Yeah.
Sorry for doing my least favorite job.
No problem.
All right, we've got Dr. Bruno next. who will be talking about leveraging B cells inside and outside of tertiary lymphoid structures.
Great. Thank you so much. Let me get this geared up. Okay. So I'm going to cap it off by not talking about a T cell, only in respect to how it works with a B cell. And so my lab really focuses on tertiary lymphoid structures, but also B cells inside and outside of these tertiary lymphoid structures. And for the purposes of this talk today, you need to understand two things, is that there's multiple types of TLS, is what we're going to call them, within the head and neck tumor microenvironment. Some of them have germinal centers, but this is the minority out of all of the types of TLS you have. And then you have some that have other hallmarks of TLS, but no germinal center. And the complexity of these structures can dictate how B cells function. And so some background on why we care about B cells. So clinically, it's been shown that B cells and TLS are prognostic with overall survival in multiple solid tumors. Head and neck is also one of those. And they also correlate with response to checkpoint blockade. And that's really what put them back on the map in 2020. There was a series of papers that came out that showed when you have these cells present in the pre-baseline samples that you get better response to PD-1, and we can talk about that later. So we really think about how do we maximize B cell function inside and outside of TLS, and it's a complicated question because TLS have multiple markers that are going to be necessary to really look at them. This is our multispectral imaging panel to really look at TLS, and you can see that B cells are one of the key hallmarks, but CD4 T cells are also here, as well as FDCs, which are follicular dendritic cells, which start to make this germinal center that I've been mentioning. And then we can look at activity of that structure via Ki67 or somatic hypermutation of the B cells. And what's been shown in the literature is that when TLS are present, there's actually increased CD8 T cell activity within the tumor and reduced immunosuppression. So that also has really gotten the field very interested. It becomes more complicated because it's not just about the type of cells that are there, but there's a lot of cues that are necessary. And so this is something to think about as I go through some of our data, which I can't go through everything today. And really what it is thinking about the initiating factors. So a lot of cytokines and chemokines are necessary. You need antigen, and I'm going to show you that HPV positive disease, when it's virally induced, is different than HPV negative disease. And then also you need the right stroma, because that's where these structures thrive, and it's actually where B cells also thrive. And we can talk a little bit about how the tumors influence this, but we won't get into it too much today because we're still working on this. And so we think about in the lab, how do we make the most functionally active TLS? And everything starts with patient tissue in my lab. So we start and we look at the patient tissue, surgical resections, patient sections, and this is all in locally advanced, what I'm going to show you today. But we now are starting to think about recurrence and metastatic sites. We have mouse models that we're working on that recapitulate B cell infiltration and TLS formation. And we do a lot of multispectral imaging and spatial transcriptomics, as well as flow cytometry and single cell RNA-seq. So we try to be very comprehensive in looking at these cells. And so what we showed a few years ago, which is, I'm just going to summarize quickly, is that B cells in HPV positive tumors versus HPV negative tumors are very different. In fact, they're so transcriptionally different that they're the most separated by their transcriptome from single cell RNA-seq. And so this is a summary of multiple papers that we put together in collaboration with Bob Ferris and Dario Vignali, really showing the differences in all the subsets. But what we really showed is that B cells are very different in HPV positive versus HPV negative disease. In fact, germinal center B cells, which would be associated more with TLS with germinal centers, are higher, and memory B cells and plasma cells were higher in HPV negative disease. But memory B cells are in both etiologies, which is important for some later points. And so the other thing we wanted to do was look at differences in HPV positive and negative disease for the TLS with germinal center versus not, or a mature TLS versus an immature TLS. And so you can see in HPV positive disease that while we often have these really beautiful germinal centers, again, this is not the norm. I would say we often see a lot more of this. But when we categorize or look at TLS with germinal centers in HPV positive versus negative disease, we see that both intratumorally and peritumorally, there are more more of these structures in HPV positive versus HPV negative disease, whereas surrounding tissue, it seems to be about even. And this is not surprising because we matched these sites for oropharyngeal tissue. So we wanted to look at the baseline there. And a lot of times the tonsil and the base of tongue already have germinal centers at baseline before the tumor comes in. We further vetted this on whole slide sections for CXCR5 expression, which is a good hallmark of also having a germinal center. And we can see that that is very elevated in HPV positive disease. So even though we have more of this, the reality is that the survival benefit with having germinal centers is there for both HPV positive and HPV negative disease. So red versus purple is HPV positive. Red are those that have germinal centers versus don't. And HPV negative, you see that survival benefit. It's just that these patients do worse overall, which we've known for a while. And so we really got interested in understanding this more than just looking at proteins, but we wanted to look at transcriptome spatially. So we adopted the NanoString geomics platform or digital spatial profiler. And we really started to look at different readouts for gene sets. 18,000 genes is the max we can do with this readout. We're now doing the single cell work, which I'll show you a snapshot of that at the end. But really what we started with was just looking to validate some of the proteins that I mentioned to you that might be up or down in TLS when they're HPV positive or HPV negative. And so when we did this and we looked at these TLS and these different etiologies, what we saw is that a lot of the key proteins that came up from the transcriptomic analyses were vetted. And so we see a lot of B cells, a lot of CD20, a lot of CXCR5, which I already mentioned, but we also see TOX, BCL6, and ICOS, which all can be associated with T follicular helper cells, which are often working in concert with B cells within these germinal centers. And even more so, we wanted to look at the difference between TLS that are close to the tumor, within the tumor, versus those that are outside the tumor, given the differences in the numbers. And we saw that tumor TLS actually have a variety of different proteins associated with them, not all of them being necessarily helpful. For example, we have antigen presentation machinery, which is not surprising given that B cells can present antigen in the tumor microenvironment, and even more so when they're in a tertiary lymphoid structure. But we start to see some suppressive pathways and some inhibitory pathways, which you've already learned about, both from the T cell side as well as the myeloid side. So this really speaks to the fact that there's different types of TLS that have differential activity, and we're really trying to understand this in the lab now and digging into it further within our patient cohorts. So pivoting a little bit, we also can use this technology to look at B cells inside TLS versus B cells outside of TLS. And it's probably not surprisingly, they look very transcriptomically different given what I just told you. The B cells inside of TLS have a lot of the hallmarks that I've already mentioned to you, in particular CXCR5, which pops up in our protein data that I showed you before. But we also see differences in genes outside of the TLS, which are genes that we start to think about might be restricting and or different because those B cells are not within a TLS. And so we tried to ask this from a very cellular immunology question while we try to understand these gene differences. And so we went back and we looked at memory B cells in both etiologies. And the reason we did that is because B cells rely upon these germinal centers, or TLS with germinal centers, as I mentioned, which is this side of the equation. But given the amount of inflammation that's within the tumor microenvironment, head and neck cancer especially has a lot of germinal center independent reactions where B cells can get educated through TLR ligands and other inflammatory cytokines. And there's different subsets of memory B cells that are present as a result. And just to put you, put it in context, a lot of these germinal center independent B cells have been defined in HIV, lupus, and COVID-19, but in the systemic portion of the patients, not in the tissues. So we really wanted to understand what was going on in the tissues. So this is just for transparency, showing you the flow plots for these different populations, but focus down here on this key. Germinal center independent is in red and germinal center dependent is in green. And so if I highlight this, the biggest thing that we saw was that we saw germinal center dependent and independent memory B cells in both the TIL and the PBL of head and neck cancer patients, regardless of etiology. But when we really started to break down these germinal center independent, we saw that accumulation of one of the subsets was very high in the TIL compared to another subset, which was very low in the TIL, but they were both accumulating in the peripheral blood. And further, when we looked at when we looked at staging of disease of locally advanced, we saw that when you had these more germinal center independent B cells, you had an accumulation at higher disease stage than compared to lower. And that was not the case for those that were germinal center dependent. So we really wanted to say, okay, locationally, where are these cells at? So we established another multispectral imaging panel where we can look for the germinal center by machine learning, and then we can put the B cell subsets accordingly based off of where they are locationally. And not surprisingly, germinal center dependent B cells are accumulating in the germinal center or the TLS with germinal center compared to TLS without or outside the TLS. But germinal center independent really accumulate outside these TLS or in these TLS without germinal centers. And so Allie Casey in the lab is really looking at this, and she started out by bridging from the work done by my previous graduate student, Ayana Ruffin, asking about the functionality of these memory B cells. And so the bottom line is we did a lot of assays, but we used the cell input from the patient tissues to look at germinal center dependent versus germinal center independent B cells with cues that would differentiate them toward plasmablasts in normal conditions. And the germinal center dependent differentiate just fine, but the germinal center independent here do not. And further, they make far less antibody than the germinal center dependent B cells. And we also did a whole host of other assays that I can't show you. This paper is currently in final revision, hopefully. And we can see that their BCR signaling is down, their antibody production is down. They both isotype switch, but they don't differentiate to B cells. These are more reliant upon glucose, the germinal center independent, and their mitochondrial integrity is down. So in general, their functionality looks to be more akin to what a quote unquote exhausted B cell may look like. And so now what we're really thinking about to wrap up is not only thinking about the TLS and what's happening with the B cells within the TLS, because we know those are important. We've established that in the field, but thinking about B cells inside and out of TLS and how these different therapeutics, a lot of what we talked about today, modulate these cells. And we're doing that now through unique clinical neoadjuvant clinical trials at Pitt, and those data are underway. But what I would leave you with is that probably what needs to happen is there needs to be a mixture of these different types of cellular neighborhoods, because these are very increased in HPV positive disease, and we get very good humoral immunity, very tumor specific humoral immunity as a result, most likely, and we're testing this now. But these independent reactions that we see that don't rely on a germinal center, they're also very abundant and they have to have a function. So whether that's reinvigorating those B cells, as I showed you, to function better and make more antibody, or maybe they have an alternative function, which is what we're looking at, such as antigen presentation or directly educating CD8 T cells, which would be important if you're trying to increase efficacy of things like anti-PD-1, for example. So the final thing I'll leave you with, which is the new frontier, is this spatial transcriptomics, which is single cell based. This is the first snapshot in head and neck cancer patients. And so what's really intriguing is that if you look at these niches here that we would normally categorize as the same type of cellular neighborhood or same type of early TLS, they look seemingly the same by imaging. But when we do the single cell spatial transcriptomics, we start to see differences, such as this niche has a lot more fibroblasts and macrophages that are influencing it, whereas these look more similar. And then if you look at the other spectrum, two different structures that would have more of a germinal center phenotype, you start to see that certain subsets like PDCs, which are these plasmacytoid dendritic cells, seem to pop up, which we would never have seen with just basic imaging. So this is the new frontier, I think, and where we're headed with a lot of this work, and trying to understand truly at a single cell level spatially how the tumor, the stroma, and the immune cells are interacting to influence these cellular neighborhoods and B cell responses. So with that, I'd like to stop and thank my lab. They're very hardworking. We went and had a TLS paint night. That was really fun. All the people in head and neck that I work with, I also work on a lot of different tumor types, because we're really trying to look at this from a multidisciplinary standpoint. And I really want to thank my funding, and most importantly, the patients and their families, because without their tissue, we can't really study these important questions. So with that, I'll stop and happy to take any questions.
Thank you, Dr. Bruno, and thank you to all of the speakers. That concludes the seminar portion, and now we're going to have a brief discussion. We may run about 10 minutes past the hour. If anyone is interested in continuing on, please ask your questions in the Q&A section. And I'll start us off with one more remaining question in the Q&A box is, are there any studies that use tumor-specific mRNA amplification of tumor-specific antigens to enhance the immune response, similar to the mechanism used in COVID-19 vaccines? Would any of the panelists like to address that?
I think Dr. Ubaluri has specific expertise in this topic.
Really? The short answer is I'm not sure. I thought that there has been some work. Natalie, have you done some work, right, in terms of getting tumor-derived transcripts as vaccine approaches?
Yes, there are some tumor-derived vaccine approaches that have been successful. There's been a study looking at pancreatic cancer, and my lab is currently looking at tumor-specific mRNA vaccines for head and neck cancer. And we're very much excited about the preliminary data and working on starting a phase 1 clinical trial at Cleveland Clinic using our vaccine formulation. So we do use tumor-derived mRNA to target specific antigens within these tumors. And we found increases in T cell activity as well as dendritic cell activity, significant anti-tumor activity, and synergy with checkpoint inhibition. So hopefully we'll get that out soon to contribute to the field of work.
I would also say that probably even if you didn't look, Natalie, that the B cells and the TLS are probably responding as well because they thrive on antigen. So we are really interested even leveraging some of the trials at Pitt that do vaccines and look at vaccines in general and seeing how that benefits the tumor microenvironment. So
Yeah,
that's really cool. Yeah.
Julia, we have significant increases in B cells. So I would definitely love to talk to you
Sure.
about our finding, because it's actually the immune cell that's most increased within the tumor out of all the immune cells. So yeah, you're right. Absolutely.
It'd be cool to see if those cells that I was saying are not working are now working better as a result of that therapy. And there's ways that we can look at that, right? And especially because you did combo. So I think that's really cool. Yeah.
Great, thank you. And so I'd like to follow that up with hearing from the panel a little bit about what you think about the role of CPS, tumor mutational burden, and some of the other emerging biomarkers that have been used in the recurrent metastatic space and how they might play a role in the neoadjuvant space. I think we know a lot of trials are not powered on biomarkers, but may be really important in identifying patients that can actually respond to these therapies.
I can start and maybe Jonathan can comment here, but overall, at this point, it's still all exploratory in terms of some of these biomarkers that we're talking about. I think there are some correlative findings. For example, in our early studies, we saw that tumor PD-L1 expression was associated with a neoadjuvant immunotherapy response. TMB was not associated with the immunotherapy response. But ultimately, as in the recurrent metastatic setting, my sense is, and I think sort of composite biomarkers will ultimately be the key approach here. At this point, we're kind of, I don't know, stuck with is the right word, but PD-L1 is a biomarker, and I think that's probably still going forward will be used as stratification in these studies. And so in that sense, in terms of Keynote 689, if it's a negative study or a positive study, looking at PD-L1 as a sort of stratifying component will be something that we can learn from, I think. Clint, your thoughts? You're nodding.
I agree with Ravi fully. One thing I think it would depend on what combination you're doing. I'm very excited from both Clint and Ravi hearing about the CD103 CD8 T cell, the resident CD8s, to see if those actually pan out as a better biomarker. Sounds like very promising. The other thing I wonder is how much is the baseline going to matter in predicting the therapy, whereas as opposed to what we do to that tumor as a result of our therapy. I think, in my opinion, inflammation is going to stand out as a big biomarker eventually with time. But yeah, I'm no longer convinced that it's the baseline of what the patient presents with, as opposed to what we're doing with our treatments to the immune system. So, but we'll see. Time will tell.
I think that's a great point. Just to follow up on that really quick, Chad, I think that sort of adaptive approaches where some of these approaches where you give an initial therapy and then do an on-treatment biopsy and then stratify based on that I think those would be kind of smart ways to proceed in the next sort of iteration of some of these trials, because we kind of stratify up front, like Sana was saying. But it's a really good point, is like what the response is, and can we modify that on treatment? I think would be a kind of a really smart way to go about the next steps.
And maybe this patient does not need the second fraction of radiation or this second segment. Yeah, totally. Maybe we're going to overstimulate or overinflame and get suppression on board. So yeah, I totally agree.
Or move on to surgery, or give more, make those clinical decisions too. So yeah.
Yeah, I was particularly struck by, some of your early findings, Avi, where the increasing timing led to increased path responses, right? And sort of following up on this idea of, is there a future you see where there's potentially like induction regimens, testing interim responses, and then modifying? I mean, I know we talked about that a little bit, but maybe we could expand on that.
Yeah, I mean, I think that's extends from the previous question here, that some sort of adaptive approach would be important. We and many others have seen sort of some patients respond, some patients don't respond at that surgical sort of specimen analysis. So moving forward, I think some sort of approach where all patients get the therapy, you do a biopsy, check for B cells, check for, something like that. I think there's some sort of biomarker at that point. And some of these early studies are already giving us hints about that, right? So I think that's where being smart about the biology and thinking about what those would be a good way to go. So and all the work that many of us have done is just at the baseline biopsy. But I think this is sort of the next iteration that we should really think about, is in a successful response, you see X or Y, and can you use that to stratify?
Or blood. Biopsy would be great if possible, but can we establish these blood biomarkers over time as well to kind of get an idea.
And I think that the biopsy issue becomes a problem with the TLS work, particularly, right? Because you can miss. So one thing that we're working a lot on is we have signatures that we've developed in situ from TLS, from the spatial transcriptomics, and now we're using biopsies to then see if that vets, and we go back to the whole tissue section and say, does it actually predict if patients had TLS at the pre-treatment or post-treatment? And then to the point earlier that Sana was making is at post-treatment that signature changing, right? And what does that signature look like, and how is it being modulated? And I can tell you from the early data from our neoadjuvant trials that the interactions that B cells have in the neighborhoods that they form are very different depending on which agent you give them up front, whether it's PD-1, whether it's combo, whatever it might be. So I think that that's going to be really important for the biology, especially.
Great. I think we have time for 2 more questions. Here's one audience question for you. Have you all noticed changes within the myeloid compartment of the TME post-treatment that might influence outcomes, either RT or ICI?
Yeah, so I'll probably answer that one. So in our Bintra study, we found that we've known for a long time that these head and neck cancers, largely because of some of the genomic alterations that are really common amongst them, produce a lot of chemokines that recruit neutrophils into these cancers. And a lot of these HPV negative head and neck cancers are loaded with neutrophils. And when the neutrophils come in from the blood and the microenvironment, they really get programmed to be immunosuppressive. And in the 20 patients that we treated with the bintrafusp alpha, which is that PD-L1 TGF beta trap in the neoadjuvant setting, pre-treatment and subsequent decrease or non-decrease of those neutrophils after treatment was strongly associated with a degree of pathologic response. So the degree that in that 4-week window you had evidence that there was an immune response that was sufficient to really kind of cause, as Dr. Blair described, necrosis or areas of cell death in the tumor. So neutrophils are a hard problem because there's myeloid cells are a hard problem because some of them are good, right? You want some of those myeloid cells because they really serve as antigen presenting cells. And even some of the antigen, macrophages and dendritic cells that maybe initially pre-treatment are programmed to be immunosuppressive, there's probably ways to salvage those and really flip their function into being antigen presenting cells, which support immunity. And really the same thing for neutrophils. So the short answer to the question is, yeah, myeloid cells are a very important component of the immune system within tumors. And on a quantification basis, myeloid cells dominate. I mean, when talking about HPV negative cancers, HPV positive cancers are different. I mean, we see some HPV positive cancers where the most frequent immune cell in the cancer is a T cell, for example. HPV negative cancer, the immune compartment is really dominated by myeloid cells, and they really drive the phenotype of the cancer, whether it's supportive of anti-tumor immunity or whether it suppresses anti-tumor immunity. And it's a big problem, and someone should figure that out.
With radiation, we see the same, and they are the most difficult problem because of what you just mentioned in terms of they serve which subsets do you target, and we don't have good targeting strategies, and the neutrophils are a nightmare. Yeah.
All right, with that, we're approaching 10 after the hour, so I think it's time to call it. I want to thank all of the expert panelists for their presentations and discussion, as well as the audience for staying late and attending, and we really appreciate your time. At the end of this, we will be sending out a survey. Please fill out if you have any suggestions for how to improve. The AHNS Research Committee would very much like to improve the offerings that we have, and we're open to any feedback. Thank you for your time.
Thank you.